What's up, everyone? Welcome back to RT Clinic. Today's video is for some ICU nurses learning to use the Drager V500. So I go over a lot of kind of entry-level aspects to the vent, some things to look out for, some buttonology, and a little description of the modes. So hold on to your seats. Let's go. Okay, so to get started, this is our Drager V500 invasive ventilator. It also does non-invasive ventilation, and it actually does oxygen therapy too. A lot of people don't know that, but it does. So we're going to go over today just mainly mechanical ventilation with it, invasive ventilation, which means via a trach or an ET tube. So some of the most important types of ventilation. So on the back, let's rotate this dude around. This actually has a place back here to hold a couple tanks, so you could transport with this. We do not, but you could. It has some doors on the sides. There is a little switch that I hesitantly tell you about on one side. It's right there. Don't ever shut it off, because if you do, it stops communication between this, and it really goes crazy and beeps really loud. So I'll show you the on-off switch, which is very important. One other important aspect is it has to be plugged into air and oxygen at all times. Inside of this is a blender, so it has what's called a proportioner valve. So the pressure will come in from air and oxygen. It will proportion it appropriately to give you the FiO2 that you have set. So you always have to have those plugged in. There is, if for some reason we had some kind of natural disaster and we lost air, we could pull air off, put it on 100% oxygen, it would work and not beep. Other than that, if one of these pops off, it's going to beep because it can't proportion the air oxygen appropriately. Now, there are some of these vents that have another big box on the bottom of them, and it is a compressor, and they can be used up on the floor, because on the floor they don't have compressed air. They just have oxygen, so they put an air compressor. First thing, let's talk about the circuit a little bit. So what do you know about the circuit when you look at it? Well, just look, come and look, and just tell me exactly what you think, what goes where. Air goes in here, goes out here. What do you think about it? It's kind of important to know, because first thing, where's the inspiratory limb? We have two limbs of a circuit. Which one's the inspiratory limb? The top one. That's, well, okay, so this is super easy. Now, respiratory therapists, we keep it easy, okay? There's an arrow right here pointing downward. Tooth patients, arrow pointing back. So we don't even write inspiratory, expiratory. We write arrows to show you. Pictures are better than words. So this is inspiratory, and this says EXP on this says ISP. But anyway, so inspiratory, why do you care about this? Because if something comes popped off when you're in here, it's nice to know where it goes, okay? So if this pops off, obviously you're gonna try to find a connection for it, and there it is. Another thing that we do as respiratory therapists, we troubleshoot. So first thing is, if you have an alarm, we always look at the patient first. Is it the patient having trouble for some reason? If we determine that it's a patient issue, then obviously we can try to fix the ventilator to help that. But sometimes it's a ventilator issue, and that's bad, because the ventilator does definitely affect your patient. So what we recommend in those cases, your patient's alarming, the vent's alarming, and maybe the patient's having some difficulty, and you look and you're like, the endotracheal tube's in, they seem to be breathing, but something's wrong with the vent, it's going nuts. Easiest thing to do in the world, and highly recommended, you grab the back valve mask, you attach it to the endotracheal tube, plug it in oxygen, and ventilate them, and then you call RT. Where's your back valve mask in this room? Awesome, right on the side of that, right on that thing there, or sometimes behind too. Yeah, sometimes behind these, but right on the wall right there. Always know where that is, because it's real important. So the machine can do crazy stuff. Like this stuff could just like pop off, and it will go crazy wild, and the patient will decompensate. It's really easy to fix. You take the patient off, you call us, we come troubleshoot it. I'm going to give you a little bit of a background on this because what kind of patients do you think pop off the ventilator quite a bit or could?
Maybe if they're hyperventilating or
Rotor-prones, right? There's so much stuff going all over the place. So it's really important. If you see something pop off, you know exactly where it goes. Respiratory stuff is really nice because it only fits in the hole where it's supposed to be. So inspiratory, let's just talk about it a little bit. Inspiratory limb, in this case, is blue. How do I know it's inspiratory? Because it goes through a heater before it gets to the patient. So we have to heat and humidify the air to 37 degrees Celsius. That's what we have it set at. And 100% saturated with water. That's why we have the water bag that kind of flows into this concha before we deliver it to the patient, because dry or cold air causes bronchospasm. Patients don't like it. Nobody likes it, really. So you always see the inspiratory limb. In this case, it's blue. I could flip these limbs and they would do the same thing, but in this case, it's blue. You also see a bunch of wires hooked up to it here. So it actually, inside of this circuit, there is heater wires, and they warm up 37 degrees so that it carries the moisture all the way out to the patient. If this wire stopped working for some reason, you are going to have a mass quantity of what we call rain out. So you're going to have 37 degree water, 100% saturated here, and it's going to come out here and start to cool. It's going to rain out. You got tons of fluid in the circuit. If you got tons of fluid in your circuit, you probably have a problem with your heater. Respiratory therapy can troubleshoot that. This also has a very annoying alarm, and I'll show you that in a second. But if you have those problems, they are annoying, but they need to get fixed, because if not, your patient's not receiving adequate humidification. And a lot of times it's easy, we just change these wires out. So we got plenty of these. So the expiratory side, as you can see when it goes to the patient, if you're ever looking at a circuit, so this is good quiz for later on. They should put this on some kind of nursing test, but they don't. So if you're looking at a circuit like this, you always know whatever side the heater probe is on is the inspiratory side, because we don't want it, because it's like 45 degrees here Celsius. We want to make sure it's 37 here. So it changes its temperature to get 37 here, because we don't want hot or cold air on. So wherever you see this, that's the inspiratory side. So it hooks to a piece of corrugated tubing and to a piece of suction, and then expiratory side comes straight back into here. Inside this guy is a little piece called a flow sensor. It has two extremely small wires. You can check those out. If you hold them up to the light, that is where every bit of our patient values come from. Those two wires. So those wires are heated to a specific temperature. When the air flows by them, that's what gives you all the stuff on the screen. As you can imagine, these get broken and they stop working. We got to put new ones in. These are reusable. So anyway, this is an important area because you have to get that air coming out. So why do we put somebody on a ventilator? First thing.
Keep their own airway.
Very good. There's one good reason.
Sometimes they just need to rest. They're in so much respiratory distress, they need to give the body time to rest.
Great, so respiratory distress. So how do we know they're in respiratory distress?
Dyspnea, ABG.
Yeah, arterial blood gases. So
Not reached.
okay, so VT not reached, so tidal volume not reached, pressure limited. Man, okay. So why do we put somebody on this? So because we need to ventilate them. We need to get rid of CO2. Even if they're a normal person, doesn't have a everybody has a CO2 issue if they stop breathing. But even if we need to ventilate anybody on this. Look at across the bottom is our settings. That's what we set on the patient. And over here is the data that comes from over here on the flow sensor. So this is what the patient's doing. We can control these, and they usually manipulate these. First thing with this patient, you're like, okay, it says pressure limited, tidal volume not reached. Okay, well, how much tidal volume do we want to give? If we look down here, it's set at 510. Okay, so if I give Lindsay 510 milliliters, I expect to get about 510 out. If I get 500 out, I'm okay. If I get 490 out, I'm okay, whatever. The ventilator is actually going to change the amount it gives to try to get the exhale, because that's more important, the exhale to what you have set. I go over here and look, exhale tidal volume, 279. wow, that's a problem, right? Because I want to give 510, but I'm only getting out 277. That's real bad, because how do we ventilate? We have to get the air out. I don't care what you give it in. And the reason we're not getting it out is because we're limiting each breath with the pressure. And that's just because of the test lung. Could definitely happen to your patient though. So any alarm that comes up here needs to be addressed, even if it's not like a red alarm. And it's really cool that you guys got this, because we don't see that a lot of other times. Now, what this vent's gonna try to do now that I got rid of that, it's gonna try to shoot to that tidal volume we have for a few breaths, but when it can't, it'll come up with this.
So it just beeps like that?
Yes, it just beeps like that. Yep. Because what this vent does, so in the, let's say the olden days, the old vents, if your peak pressure, that red line was set at 40 or 45, the vent would go shh and hit it and stop. It would go hit it and stop, hit it and stop. You'd be given like 25 mLs for a breath. The vents are more advanced now, because what it does is it goes and hits it and stops, and it says, well, I'm gonna try to get closer. So it drops some pressure and tries to round it off so that it gives more of a breath, although it's not giving a full breath. But it still gives you a little alert. Pressure limited, tidal volume not reached. Just, I mean, it was a month ago we had a patient back here that had that running for probably 6 hours or so maybe. And in that case, what do you expect your blood gas to look like in the morning? Poor. Yeah, you're gonna have respiratory acidosis, probably CO2 is probably gonna be high, unless they're taking some spontaneous breaths. This patient was fine, but I mean, it's just one of those things. You're like, ooh, want to run my blood gas bad when my exhale tidal volume is low. So anyway, it's a little small alarm. Let's show a bigger alarm. More concern.
So will that stay up there until that's fixed?
Yes.
Or, okay.
Yeah, it'll stay until it's fixed. 2 ways to fix it: more compliant patient, which I can't do much with this guy, or I could change the alarm.
It's not something that like intermittently pops up.
Well, it could, like if, let's say, I'm gonna turn this volume down real low just because the test lung's being kind of a pain. But it could pop up like intermittently, but it should go away like in a couple breaths, because it's gonna fix itself. All right, I caused an alarm there, so I'm gonna go back. So let's say this is not accurate for an adult. But let's say we're on 253 as a tidal volume. Exhale tidal volume is 267. I'm good with that, right? They're correlating. That's not accurate with an adult. Let's just say if we did it that way, because my test lung's kind of being a pain. So let's do a red alarm. So if something pops off, red alarm, disconnect. It escalates in sound. The sound escalates. Even if this is faces away, you can still see the red on it, okay? So you come into the room on this patient, first thing you're gonna do is you're gonna check on the patient, okay? Is there a problem with the patient? No, there's not a problem with the patient. You could even, if you're not for sure, see how it gets louder? If you're not for sure, take them off, attach them to back valve mask, ventilate them, call RT. It's better to do that than to try to troubleshoot this and fix it. And what makes it really hard to fix is this sound in your ear, because it's super annoying. And you're like, I'm trying to think what's going on and I can't figure it out. Now I have a low minute volume alarm. My disconnection's fixed, because you see it's like in the blue. My low minute volume is now alarming. And it's not gonna come up until it gets above my alarm. So
you're not even necessarily sure if you fixed it once you fix it.
Exactly right. Because you're gonna be fiddling around like, did I get this right? Did I get this right? And you're not gonna be sure. So when those red alarms happen, check on your patient first. Make sure the tube is intact and all that kind of stuff. And if you look up, just glance at the vent. If you're like, I'm not for sure, this is what I would do. You know, I would, if they come off and you're like, okay, you don't see that, because there's all kinds of stuff around. You don't see that. You come and check on your patient, get a back valve mask, hook it up, attach it, go right here. There is some audio pause, just so I can think for a second. Call RT. I'm good. I don't need the vent if I'm ventilating with the back valve mask, okay? So it's always a good thing to kind of do, because even if I do fix it, it's still gonna have a delay, because our minute ventilation, which is respiratory rate times tidal volume, is still gonna take some time to come back up. back to where it needs to be. Now here's an interesting thing. So when I silence that, it does leave it silenced for a long time. If a different type of alarm happens, it will alarm over it. So you're not silencing absolutely everything. It just does that specific alarm. So let's say you heard that alarm. You came in here and now you're like, okay, there's no alarms right now. Say that's shut off. You came in, there's no alarms right now. Everything seems to be attached. What was the deal? Why was it red alarming? Every red alarm or yellow alarm will be right here. This is in the alarm history. So this is what we're absolutely okay. If you come in and you say, low minute ventilation disconnection, I mean, okay, we're good now. You know, you might think, disconnection, why'd that happen? Well, maybe the RT suctioned or something. When you suction, it thinks it's disconnected because you're pulling the air away. So maybe they suctioned and didn't use the right button. Or you could also just check connections, like, did something pop off here? Because I don't want it to do it again. So then you just touch it, confirm it, and it clears the top. I like to have the top clear. Because then if it alarms for something real small, there you go. So it's going to still red alarm, but then you come in, you're like, okay, what in the heck just happened? And you know, something popped off at that time. So. All right, so those are a couple different types of alarms that you're going to see. It's going to slowly build this breath back up. So one common thing that you will change is oxygen. So if you get a change for an oxygen order, they give a titrate of oxygen order. Definitely you change it. I'll show you how to change it. When you change anything, you want to verify it is changing on this side. So we see that FiO2 is here and the actual reading is over here. So you just come up, touch it, adjust it, and confirm it. Just change it to something. Go for it. Anybody?
Oh, like me?
Yeah, go for it.
Sorry. Okay, you want me to change this?
Yeah, make it 65.
Oh. I don't know how to make it 65.
So remember what's on that side. That's what the patient's doing. Where are the things that we change?
We want to go down.
Yeah, there you go. Touch, adjust, confirm.
Oh.
Bingo. Now, watch your number up there. It should, that's a couple of breaths. It should come to 65. So that's how you know you did change it to 65.
Okay.
Cool. Second thing that we can change FiO2 with is our O2 suction button. So a lot of buttons on here. There's only a couple that you really need. O2 suction button is one of them that you use every time you suction. It does two different things, and it does it really well. What are you taught in nursing school that you're supposed to do before you suction? Hyperventilate, actually hyperoxygenate. So that's what it does. It actually gives more oxygen. So we give more oxygen. So O2 suction, we touch it, it's yellow, right? I gotta confirm it. When I confirm it, it does two things. It gives 100% oxygen, so watch your oxygen. It's gonna shoot up really fast. This doesn't change down here, just that. And it says disconnect patient after O2 enrichment. So essentially what it's telling you is it's okay to disconnect the patient or it's okay to suction the patient. Because when you suction a patient, it's just like, it thinks it's disconnected. So years ago, before we had inline suction where you go down and suction, they had to take people off the vent, stick a catheter down, kind of do it old school way. Thank goodness we don't have to do that anymore.
Yeah.
So they would take them off like this, they would suction them, cause a lot of nosocomial infections, VAPs and things. Once it's done suctioning, you see it's not alarming right now, no patient on. It says perform suction, reconnect. So as soon as it reconnects, it senses it. There you go. See, it senses it. Final O2 enrichment. And once it does the final O2 enrichment, it will drop the FiO2 back down to where it was before.
So it just gives it like an extra shove of oxygen and then it goes
Yes,
back
it
down.
does. Yes, it does. Which is really good for your patient. But if you're working night shift and you know we do blood gases at 5 a.m. in the morning, it's not something you want to do before the blood gas is done, because if you give them 100% oxygen, just a little bit of that, they'll jack and their PO2 will be off. And then we'll have a PO2 level, be like, what, it's 65 and the PO2 is like at 600. It doesn't make any sense, right? So you're gonna make sure that you don't do that before a blood gas. Now, I think they tell us 30 minutes before. Technically, like 15 minutes before, it should be able to clear it out. By the time their sac comes back down to where it was before. So in this case, you see, what's this problem? Leakage. So there was a leak in the system. It was because I had them off for that long, but it fixed itself, self-resolving. It tries to fix everything on its own. So O2 suction is a good button. Now I'm gonna show you the downfall to it. So if Ashton was getting ready to suction her patient. And she comes in and she's like, okay, Jimmy said to do it this way. And you go to suction your patient and then you get called for a code and you leave right now. So you leave right now, go to a code. Bad news because what you're doing is you're telling your ventilator, I'm getting ready to suction, it has 180 seconds. So if you leave and the patient coughs and you go out, you take off, it's not alarming if they pop off. The next alarm that you'll get will be from the monitor when they're desat or something. So it's really important to do, if you're gonna hit that button, make sure you do it, and when you're finished, cancel it. So I'll show you that real quick. So it's a great button, but I don't like it for that reason. It doesn't know if anybody's in the room, which is perfectly normal. No machine really would, hopefully. But if you're gonna go to O2 suction and you're gonna do it and you get called away, touch it again, confirm it. Now your stuff's active and you walk away, it's going to alarm. So, and that'll bring you back, hopefully. Okay, so that's kind of the gist of the things that you might use. We have a nebulizer on here that you'll see the RTs put in line. That doesn't affect the blood gas. It nebulizes from a little port right here. Let me change some settings here, try to get something a little more interesting. Oh, I should have brought a better test along, but.
So what do you see the yellow alarm for? Like what type of mechanical issues?
A lot of things. The yellow alarm is something that usually can be resolved very quickly. So, okay, let's do this. So we set kind of generic alarms on the patient. So I touch it, you can see these generic alarms. Mm-hmm. So one of them is respiratory rate, and it's set conservatively at 24. So right now you can see our respiratory rate's 15. I'm just getting crazy with it. So the patient rate over here is 20, 23. That's actually a red alarm. So if they go above it, it's gonna be a red alarm. Let me try to think another. And then high minute ventilation is another one. So I'm hitting both alarms at this time. So high minute ventilation is respiratory rate times your tidal volume. It's your perfect number for ventilation. So in this case, you come in, you hit alarm silence, see what's going on with your patient. You know, are they really breathing that fast? Is there something going on? Do they have a big old chunk of mucus that you can see they're kind of coughing on? Are they waking up? Did they pull their tube out? Whatever it could be. Those different things. As they resolve, they will go away, which is nice. So then you heard it happen. This will happen a lot. If you're weaning somebody and you step out of the room, the respiratory rate goes up, you come in, red alarm, you come in and it says respiratory rate high, and they're like right on the border of their alarm. So they just went up for a second and came back down. So, what other yellow alarms? I'm trying to think. What are some yellow alarms? Let me see if I can call
That's okay, I'm just curious.
Yeah, I mean, maybe I could do minor leakage. I don't know. There are some yellow alarms, but I don't know what they are. I'm trying to think what they are. Yellow alarms are nothing going on really bad with the patient right now, but it needs to be addressed. But the blue one is one that's a very interesting one. The leak or the other ones are very of their own concern. You know, it's not a yellow alarm, but it's like somebody needs to come take a look at this because they're not getting the volumes they should in these cases. Okay, so generic breakdown of what's going on the screen. This is pressure over time. Oh, we're back at that again because our test line is not non-compliant. So this is pressure over time. So pressure goes up with the breath and it comes down. This level of pressure that's always kept inside the lungs, what do you think that is? That's a setting that we put in the computer, or put in the vent. There's a pressure that's always kept, especially at the end of expiration. Give it away.
CO2 remaining in the lungs.
No, it's a pressure, so it's something from down here. PEEP, yeah, positive end expiratory pressure. So see that little line right there? That's at 8. If I go to this and go, I turn it up, watch what happens to the line after the next breath. Gotta confirm it, James. Look at that. That's your PEEP now. Well, it's really high. So you see it doesn't come back down the baseline because I turn that PEEP up. Mm-hmm. So that is your PEEP. So that's your pressure waveform on the top. We try to keep 8 of PEEP, and that's just to prevent ventilator-associated events. Pressure limited breath again, so you see what happens there. This is our flow. So this is the air going in, and then there's the air as it exhales. So it goes in, it holds, and it exhales. And why does it hold? It's because this TI is set too high now. This is nothing you need to know. But if that's inspiratory time. So if I turn that down, this will be a little tighter together. Should be at least. So it just doesn't hold it quite as long. And there's the expiratory side. This is the volume that goes in. So each one of these should line up. So if a patient breathes on their own in assist control, it finishes the breath flow. And you can see how the pressure kind of correlates with this. Now this balloon is junky. So our volume should not look like that. They should look more like that one. There you go. See how you got the pressure waveform? So your pressure, flow, and volume are all associated. So that's the way it kind of should work, should look. Let's go into modes real quick. Oh yeah, I didn't like that. Let it get back to normal. So what do you think a normal respiratory rate would be set on a patient? Respiratory rate's right there. 12. Yeah, because it's in there, right? 12 to 20 is really normal. So 12 to 20 is normal. FiO2, of course, you wean for sat. PEEP, we always leave at 8. Don't worry about TI, don't worry about slope. And then tidal volume is usually, it used to be 10 milliliters per kilogram ideal body weight, but they've erring more on the 6 to 8. Generically, what that means, 500, 550, 600, 650, 700-ish, somewhere in there. There's a nice little thing I have on my badge. If anybody's interested in this is on eBay for sale. So, that's on my badge, and it says right here, oh, we have 8 mils per kilogram for how tall is she or how tall is he, and that's how you determine what their volume is. So, anyway, it's nice to know. It also tells you how to blood gases, but you guys wouldn't have trouble with that, I'm sure. So, all right. So, we know what's going on here. Let's talk about the modes, and we'll go through the easiest of the modes. So, VCAC, that is volume control, assist control. So if you're giving a report to the next nurse, you're gonna read the vent settings like this. You're gonna say, patient's on assist control. We don't do the volume control thing, we don't worry about that. Assist control, rate of 12, tidal volume, 330, which is not what it would be. Say 550, PEEP of 8, FiO2 of 65. That's how you read them. So if you're reading to somebody, you're saying they're on AC of 12. What that means, assist control rate of 12. Okay. If they get any deeper, it's 550 for a tidal volume, 8 of PEEP, FiO2 of 65%. Some people will say 0.65. You're like real technical. So that's the way you would read those. What's special about assist control? Assist control is what I term to the families as the resting mode. So if your family member's on this, I say they're on the resting mode. We're going to do every bit of work for them, but if they take a breath on their own, we're going to finish it every time. They start a breath, we finish it. We don't block them from breathing, but we finish every breath. So as you can see, 12 breaths per minute. Let's say Joe Smith here starts a breath on his own. The ventilator, finish the breath to a volume, what we had set, every time. That waveform is jacked, so just don't forget that waveform. But you see how it came up every time? Every breath, wait, it must have a hole in it or something. So every time they breathe, it gets finished. And you notice this here, these are all blue, which means those are all ventilator breaths. So assist control is, we're gonna give you 12 times a minute, we're gonna give you 12 550s per minute. If you take your own breath, we give you a 550. So you can breathe 30 times a minute, but every breath's gonna be 550. We don't want you doing any work at all. We're not gonna block you. We don't want you doing any work at all. So this is why it's the resting mode. So you can wake a patient up on this. They can breathe 20 times a minute with this. It's gonna finish the breath for them. They're not gonna do a lot of work. But if they haven't been on the ventilator for very long, it's not gonna be a big deal because they're still gonna have the muscle there to be able to breathe on their own. So you'll commonly see, not commonly, but sometimes we'll see, you wean somebody from assist control, put them straight to a CPAP and pressure support, and then extubate them. So you don't have to go to the middle mode. Let's talk about the middle mode a little bit. So this is full resting mode. The next mode, I'll show you, is VCSIMV. So synchronized intermittent mandatory ventilation. You don't need to remember it, just remember it's kind of a middle ground. So in SIMV, the generic aspect of it is we're going to give them 12 550s, this says 330, but 550s per minute. If they take their own breath though, we are not going to give them 550. We're going to give them help, what we call pressure support. So we're going to support their breath a little bit. We're not going to finish it though. They got to do a little bit of work. So you can see that volume is not quite as big. And you can see now we have these little gray ones on the flow. I'm sorry, brown ones on the flow. Those are spontaneous breaths. The one thing you can guarantee about SIMV though, you're always going to get 12 regular breaths. So as you can think, well, you say, well, I'll start them off on 12. Maybe I turn the regular breaths down to 10, and I turn it down to 8, and I turn it down to 6, and I turn it down to 4. Now, some doctors do that still, but it's kind of really slow. So what we usually do is we have them woke up, we put them on this, we put them on a low rate SIMV. So we'd watch them. We give them a few breaths per minute, but we make them do a little bit of work on their own. So let's say like 10. Most people don't, 8. Most people don't breathe 8 times a minute. So we expect them to breathe on their own in these cases, and it's going to support them. We're giving them the pressure support, that's it right there, to kind of overcome the tubing. And the family says, are they breathing on their own? And you can, and this, I've told them if they're watching, I tell them this, see the brown lines there? That's when they take their own breath. They'll also ask you if they're breathing on their own, if they're in assist control. And I always say this is a resting mode. They can take their own breath, but we finish it for them. We don't make them do any work. They gotta do a little work on this one. I also show them this, which is probably too much information, but I say, see this number right here? That's their total numbers of breath per minute, and then this is how many we're giving them. The difference between those two is how many they're starting on their own. They like to see that. So SIMV is kind of a middle ground. Now if they somehow start reacting different to the sedative or something, or somebody turns it up and they stop taking spontaneous respirations, we know that they're still going to get 8 550s per minute. That's really not going to be enough. So you're going to see that probably trigger an alarm when they stop breathing on their own. If these things happen, and I'll show you what the next mode, the ventilator has a fix for it. So let's go to the next mode. It's going to be called spontaneous SPN CPAP pressure support. Now see all those settings? We don't have very many now. Because all we're doing now is we're saying breathe on your own, buddy. And then once you do well, we're going to draw blood gas and take you off the ventilator. So as you can see, this patient, and these waveforms are actually real nice with this lung. This patient starts a breath, and the machine doesn't give them a full breath. It just gives them 10 of pressure support each time. So it simulates you breathing on your own. Because why pressure support? Well, I don't get pressure support when I breathe on my own. No, but you're not breathing through a circuit in the tube. So we're overcoming that with the pressure support. So this is the mode that they're in right before we extubate them. So, and usually, before we even start weaning rate, we want to get our FiO2 to 50 or lower. So you fix oxygenation first, and then you fix the ventilation aspect of it. That's why COVID patients take so long to wean, because we couldn't get them down that low to even start weaning volume. So we have extubated people at 60, 65 before. It's not much more than that, because if they can't oxygenate with 60 or 65, what's going to be the good of extubating them? Because you can't oxygenate them then. So one thing about CPAP is, if they're on this, and let's say your patient's like, you're weaning, you step out, you start giving report, and let's say they were doing well, and all of a sudden they stop breathing. So for who knows what reason. This machine will pick up, and it goes into this. So this is a yellow. Apnea ventilation. So if you come in and you see this apnea ventilation, this means they were apneic. The machine said, no, no, no. It puts them back in this AC mode. Okay, so it's breathing for them now. So right now you're like, oh shoot. So it's pressure limiting too, so you're all kinds of problems. But it's going to say apnea ventilation, and it's going to start ventilating for them. And they may start fighting because they're woke up now, it's doing this thing. So a lot of times what we'll do is RT may come in, you call RT in and say, such and such rooms in popped over in apnea ventilation. They'll come, they'll take a look, they'll probably hit this reset button. This is at least what I would do, and I would sit back, put them back in CPAP and watch them. Okay, was it, what was it? Are they on the borderline? Or, the amazing thing is, what causes us to breathe is our CO2 rise. If they they start hyperventilating and get their CO2 down real low, and then they go to sleep, they won't breathe for a long time until their CO2 comes up enough to trigger them to breathe. So maybe that's what it was. So it's nice to kind of sit with them to make sure they don't pop over in apnea ventilation again. But apnea ventilation is not like, I guess it's a great yellow alarm. It's not like, oh shoot, I need to freak out. No, because it's taking care of business right now. But if you're planning on getting a gas in a half hour, no, because they're back on a rate again. So it's a way that it kind of picks up to tell them back on a rate. So, and you'll see, it goes right back to doing it, and it will continue this until somebody comes in and addresses it. And so you can see it from the backside too. So, and it's pressure limiting on top of it. So, if you're ever wondering what size endotracheal tube they have in, it should be documented right here, 8.0. Because we put that into tube compensation. So if we set it up correctly when we did it, it should have that. Now, a couple more buttons on the other side. Let's put them back into a mode. And this is something from the nursing side that you don't do, is change modes. But let's just look at a couple of the buttons up here on this side. So, different views. If you hit something and you're like, oh crap, what is all this stuff coming? Remember, it's just like Windows, you can get out of it. You're not gonna hurt anything. Day, night, I think these trigger to change. I like this look. I don't think anybody else does, but I think we have set these up to trigger at 6 p.m. at night. They go to night mode, which isn't real bright in the room, which I kind of like. I like it during the day too, but whatever. Track trends, values, tons of values. You want to look at some, all kinds of crazy stuff. It's got all kinds of stuff you probably don't care about. Special maneuvers. We got all kinds of different things we can do with special maneuvers. What the heck is sim mode? I don't know. Wow. Okay. Anyway, I haven't seen that yet. Must have been an upgrade. Okay, nebulizer, O2 suction, you know about that one. Now, manual inspiration. This is the only button, if you touch it, it will work. Watch. So you may see RTs use that sometimes. It's like using the ventilator to bag the patient. So if I just keep hitting it, it'll keep giving a breath. Almost everything else I've got to touch and confirm. But that's one you'll see. And then the last one, which is very commonly should be used, because if we're going to wean somebody, the last thing that a nurse or a therapist wants is to get vent juice on them. You know what vent juice is? It's the warm fluid that's been sitting inside of here, and it's just as bad as like urine coming out of a catheter. It's just as bad. But when you extubate somebody, and if you don't hit this button, it will blow, and it hits people. So for infection control issues, it's not good anyway. But there's a cool button here, and the therapist might actually ask you to touch this for them for the extubate. Right here, manual disconnect. So it's one of those yellow ones. So I gotta touch it. It says, please disconnect patient. So cool, right now I can go in, it's doing its thing, but when I disconnect patient, I can extubate him, pull everything out, get this thing, shut the vent off, and it's never started blowing nastiness all over the place. So that's a really great button it's called manual disconnect, and we try to use it. Now if the patient, you're like, oh, they're not gonna wean, and they start breathing back, we just shut it off and it will reset itself like that. So, alarms on this side you won't have much to do with, and then the start, standby, this is how you're gonna turn it off. So you can hit this hard button here, standby and confirm, or you can go here, standby and confirm. Now when I hit that, it's gonna automatically confirm again. So it's one of those things that if we are terminally weaning a patient, I try to do as quietly as we can with families in the room. So I'll use 100% O2 suction, make sure it doesn't alarm or anything when I'm messing around, because that shuts all the alarms off. Use manual disconnect when we pull it out, so there's no sounds from this thing. And as soon as I go to shut this off, I go really fast, and I hit standby. That, and that's about as fast as I can get it. So you have to hit standby there and then shut that off, or it'll keep alarming. So we just try to go really quick with shutting those off. And then it's asking, do you want to shut it down? So let's turn it back on. And all you can try to hit standby, shut it off, and then quiet it after that. There you go. So it always should. If you watch the RT do something too, and they take them off and put it back on, just out of the corner of your eye. I mean, it's happened to me. I've done this before, and it's not turn a vent on. I go through and hit those really fast, and I start going over here, and I think it's on. I look back, and it's not on. So just look over. If it shows this screen, it's on. If it shows anything with that yellow standby thing, it's not. So just say, oh, I don't think you got the button right. Just go over and do it. I mean, it happens to us because we get going to do this stuff fast, and we go and do it, and then we put them back on, and I go like this, and I go, whatever, maybe I missed it, hit that. I mean, and you look away. It's one of those automatic things. So it's got to have the screen coming back here. Any questions? You guys were really good.
I don't think so.
Questions? That was a lot of information. And
That
it's
was
short
very
amount of time.
helpful though, because I've been looking at these in the room and trying to figure stuff out myself, and it was not going very well.
Yeah, so just know that if you're going to look at, when you're giving a report, your settings are on here, what the patient's doing over here. You don't talk a lot about what's going on over here in report. Mainly it's just reading this and listening when you write those things down. So, and you're giving, because that's what the next nurse is going to want to know. What were they on? Did you try to wean them? Did you not? How did they tolerate it? How long did they last? That's the one thing that they ask a lot. How long did they last before we had to put them back on a rate? How long did they make it on CPAP? Did they make it a half hour? Well, we'll try tomorrow. Maybe we'll get them for 45 minutes or whatever. So those are always really good things. Or we had to go up on the FiO2 today. We had to go up on the PEEP today. Their blood gas showed that their CO2 was high, so Dr. Goda wanted to change and turn the rate up today. So we went from 14 to 18, and that seems to be working well. I mean, just those little, it's all minor changes that you're going to give a report. And so you really rely on the RT for almost everything else, but it's just good to know exactly what settings are going on. So if you come in the next day, you can see, oh shoot, they were on 50%, now they're on 75%. Well, like COVID, they're on 40%, now they're on 100%, and we got the peak max to the most we can do. And now, what do we do next? Because once you get your FiO2 at 100, you can't go any higher. So we got something about other options. So it's just nice to see those trends for those patients. So cool. Any questions?